Good morning, everybody. Welcome to this Balint group meeting. Now, what exactly is a Balint group? We'll be looking into this. Balint is a forum where we can check our skills for psychotherapy. We can get the help of fellow professionals where we interact with somebody leading the group, but it's pretty much a democratic setup. But we need to know much, much more. This morning, we are welcoming people who are exposed to the Balint method for the first time. I am just short of 2 years old in this particular modality, and I've enjoyed being here. Let me assure you that it can be very, very rewarding. In the Balint group, you bring up your own cases, and we discuss them in a manner that can sometimes be a little dramatic, but always very rewarding. But to say more about this, we have our first session in which we'll be looking at what is a Balint group. This will be addressed by two veterans in the field who've been leading the group I belong to, that is Dr. Arun Kishore and Dr. Mathew Varghese. Then we look at what is it like to be in a Balint group by Dr. Rathna, and then finally, the Balint experience by Dr. Ashlesha. So without much ado, I have a request. Please switch off your audios and your video for the time being. We will be encouraging you to open these up when we get to our discussion stage. Also, as we go along, if you have any questions, doubts, and so forth, please post them in the chat. Okay? Thank you very much. With that brief introduction, here we are. Let me introduce our two veterans who will be introducing us to what the Balint is all about. I must apologize that I have a little technical glitch this morning in spite of my being ready a couple of hours ago, but here we are. We have today Dr. Arun Kishore, a pioneer in this field. He's a consultant psychiatrist in general adult psychiatry at Sussex in the US. In spite of being an Englishman currently, Arun is very much a part of the Indian scene. He's a trained group analyst, an expert in group psychotherapy, dynamic interpersonal therapy, intensive short-term dynamic psychotherapy, and has been running Balint groups for 14 years and is an accredited Balint leader with the Balint Society in the UK. He's also an accredited Balint supervisor and a reflective practice trainer with the Institute of Group Analysis, also in the UK. Also, alongside Arun, we have Dr. Mathew Varghese. Mathew is a well-known family therapist as well as a geriatric psychiatrist who had a very distinguished career at MIMHANS till fairly recently. Mathew is a trainer for psychotherapy as well as supervising individual therapy and couple and family therapy. Currently, he is a visiting emeritus professor at St. John's Medical College, which is his alma mater. And over to Dr. Arun Kishore as well as Dr. Mathew Varghese. I don't know who would like to start to introduce us to what is a Balint group and what is reflective practice group. Over to you, Arun.
Thank you, Ajit. And you will let us know when we've got a minute to
go. Yes.
Thank you.
I suggest one of you starts.
Yes.
I reckon you've sorted this out between the two of yours. So
this is a sort of a conversation between Mathew and myself. Mathew, would you like to?
Yeah, so I think I will start. So, as many of you might know, good morning, everybody. It's great to be here on this sort of seminar. We held this, I think, more than a year ago. And since, Arun and I started this particular Balint group running in Bangalore for the last 3 years, virtually, of course, because of the COVID. So, as many of you might have guessed, the Balint group is named after Michael Balint, who was a psychoanalyst who lived till 1970. So in the 50s, he and his wife started seminars for general practitioners in the UK. Basically, they wanted psychological training for GPs because they felt that psychological aspects of issues, patient-doctor interactions were not really being handled. So basically, the groups essentially are focused on education based on a case presentation and then a discussion. Usually the groups comprise of about 10 or 15 people, usually not more than that, with a leader, sometimes a co-leader, together with the leader. And basically the group focuses on the relationship between, for a long time it was the doctor, but now it need not be the doctor, it can be any other therapist, there can be groups for lawyers, there can be groups for corporate people and so on. So originally it was actually the doctor with, or rather the therapist with the client. So focusing mainly on the relationship between these two people, the interpersonal relationship, the therapeutic relationship. So in the old days, the group met once a week for many years sometimes. Our group, for example, just meets twice a month. If you look at what are the benefits of the Balint group, basically the leader ensures that it's a safe place where the participants can talk about things. It can avoid professional burnout. So you get to sort of talk about your patients or your clients in a closed, confidential scenario. You tend to see the patient as a human being, and you get a deeper level of insight into the patient and sometimes also for yourselves. Essentially, the groups go through certain phases. So initially, the leader starts by saying who has a case. And this is usually after the group is formed and there's been introductions all around. So there is a sort of 10-15 minutes of time when somebody has a case and people make the presentation, that person makes the presentation. So in a session, sometimes the session lasts 60 minutes, sometimes the session lasts 90 minutes, depending on how many cases you want to discuss. So there is a presentation which goes on for about 15 to 20 minutes, usually about 15 minutes. And then there's a time for inquiry when the members can ask questions. And the leader sort of ensures that these inquiries are not too much in detail and not too personal. And then there's a pushback where the presenter is asked to sort of sit back. So in a group where it was actually conducted, obviously in the beginning, in the earlier days before COVID, it was conducted in person. So the leader just asked the presenter to just push back, move the chair back, and then the group more or less sort of pretends that the person is not there and discusses the case, and then in some detail. That goes on for about 20 minutes or so. And then the last 10, 15 minutes, the presenter is supposed to come back and then talk about his or her own responses to what they heard the other participants talking about. So that's essentially what it's like. And I will now ask Arun to sort of say his piece, and then we'll have some conversation back and forth.
Thanks, Matthew. So I think what Matthew's done is to sort of define or try to define what a Balint group is. And I think my function is to try and say what it isn't or it might not be. Because there are various types of groups. Groups started in medicine many years ago. Decades ago, actually. So, for example, in teams, you have something called reflective practice. You have staff support groups, you have experiential groups, and then you have therapy groups, group therapy. So Balint groups are slightly different from all of this. My understanding is that Michael Balint, when he started the groups, actually started it as a, he believed that the doctor is the placebo. So he wanted to try and enhance the placebo effect of the doctor when they meet up with a patient. And then, of course, there were other functions that came about. So just to see what's different between a Balint group and a reflective practice group, Now, reflective practice or reflection, the term was popularized by somebody called by somebody called Sean. And Sean, very long back, he sort of pointed out, and he did this in education. He said, whenever a practitioner practices, they need to pause and then to think about their decisions or reflect on their decisions, and then try and see how their decisions relate to theory. So there's a connection between these. And he called it reflective practice. Now, reflective practice can be an individual task. For example, all of us reflect on what we do. But when that reflective practice is done as a group, the focus moves from just my practice into the practice of a group or a team. So, for example, if I work as a team, then the team sits together and reflects on what happens in their practice. So Balint is a type of reflective practice. The difference between these two is in terms of the structure and the focus. So in a Balint group, the focus is very much on the doctor and the patient, or the therapist and the patient, and what happens between them. The focus is on both the doctor, the therapist, and the patient, and their emotional reactions. In a reflective practice group, the focus need not be on just the two of them. It is on the processes that happen in a team, or what decisions are made in a team. So it's slightly disconnected from the emotional side of things. But again, reflective practice groups can be focused on emotions as well. So I said that Michael Balint started this thinking that the doctor is the placebo. But then if you notice what Mathew was saying about Balint groups, the focus shifted into being more supportive of the therapist or the doctor. And so you had what we call staff support groups. And staff support groups are essentially run to help staff deal with difficult decisions that they have to make about patients or about the people that they care for. So you had different types of groups. And this is what reflective practice groups and staff support groups are. And Balint groups are slightly different from that in terms of the structure. So there is a case. In a reflective practice group, there is no case as such. And in staff support groups, again, there is no case. The focus is on what happens in the team in that moment. So that's essentially a summary of what Balint isn't. So, Mathew, what I wanted to ask was, are there reflective practice groups in India at the moment, Mathew, to your knowledge, or other types of groups for teams? Mathew, can't hear you.
So I think some people are running groups. So Arun and I started this group during the pandemic in September 2020. And I know this group is going on. And I know that Arun is training a few groups. He's leading a few groups in Kerala and some parts of South India. I know that Sivakami runs a group for medical residents, psychiatric residents in Chennai. I know Ashlesha runs some groups in Bangalore for various physicians. But, and I know that some places like Nimans and other places where they have a psychotherapy training program, they have groups. They're more like therapy, instructional groups, rather than reflective practice or sort of Balint groups. So I'm not really aware that there are Balint groups going on in different parts of the country.
And the other thing was, sometimes supervision happens in groups, which I believe was a practice in NIMHANS at some point of time, wasn't it?
That's right. Yeah, and I think you and I went through that whole process many years ago.
Yeah.
Yeah. So it does occur in groups, and then so there's been something written about peer supervision in groups, and then these groups, at least the ones I know in NIMHANS, and I know there are ones like this which have occurred in, say, PGI Chandigarh. They basically occur with the faculty being a sort of leader in the group, and then the supervision occurring, different students presenting their cases and then discussing things, and everybody actually contributing. So that's the kind of peer supervision where everybody gives inputs, all the other students gives inputs. So that's the kind of scenario that I know of, but no, there aren't many groups running.
So if we sort of come back to where we started, which is why Balint groups and why there's a need for this. I think that there is a need for a reflective space for doctors, therapists, and psychiatric social workers, people in the helping professions, if I can use a term very broadly. I think there's a need for a reflective space because I think there is something about Balint groups that helps the doctor or the therapist, examine themselves in the clinical situation. And I think the lack of that space leads to more stress. And we'll hear somebody talking about how Balint groups help with stress. What do you think, Mathew? What the need for Balint groups in India?
Yeah, I think I've always felt there's a need for Balint groups or reflective groups, because many times what I've seen is that psychotherapy supervisors themselves find it difficult sometimes because they all sometimes wonder what is it that they're doing in a supervisory session. And I know that students or mental health students who do therapy, they're always wondering, whether what they're doing is the right thing or not. It's just reading theory obviously is not enough, and it takes many even very experienced therapists like you and I get stuck, and we learn some things as we go along, and that's something I think is very essential, that you have a forum where you can confidentially and freely, without being criticized or prejudiced, discuss issues that you have, problems that you faced in an interaction with a client. I think there's a great need for that.
And I guess sometimes I don't know whether there are teams in psychiatry in India, but there definitely are here in the UK, and sometimes it helps better team functioning. So I also wonder whether outside psychiatry, outside mental health, whether the general doctor would also benefit from having Balint groups.
Yeah, I don't really have experience on that, but I know that one of the members of our group, Ashlesha, has done some groups with other physicians. I think one of the issues that happened during the COVID, at least I know, that in many hospitals, I know that in St. John's and many big hospitals, they formed rooms or groups where they could come together and discuss issues that occurred when they were really stressed out, during the pandemic, looking after patients, with patients dying all around, and really medical services really going helter-skelter. So I think many places organized these sort of coffee rooms or discussion rooms where you could come and then discuss, and I know that many mental health professionals provided that space because I think this whole thing of burnout and fear and anxiety and seeing sort of death all around was a big issue, at least in the first 2 years of the pandemic. So I know that there is a need, and that there is a need for physicians to really come together. I know it happened during calamities.
Right. Thank you, gentlemen. I think that's been a good introduction. We started a little behind time. I'd like to catch up on time. And I ought to have introduced myself. I'm Ajit Bhide, a psychiatrist in practice for the last 35 plus years. And my focal interest is in youth mental health, and particularly in psychotherapy, not only with you, but with others as well. I have other areas of interest, but I don't need to go into that now. I was fascinated by the Balint group. I read the book in the Nimhan's library, The Doctor, His Patient, and something, I forget the rest of the title, which was quite influential. And I asked our professor, Ravi Kapoor, whether we could have a group in our institute. And he said Dr. Shyam Sundar, who was the other senior psychiatrist in the same unit, runs a group. And we had case discussions. What we have learned now is what a Balint group is all about. It is a type of reflective group, but all reflective groups are not Balint groups. So Arun has also heightened for us, elucidated for us what Balint groups are not, what to expect from it. We have largely focused in our interactions on case-based material, as I have seen it happening. But sometimes in Balint groups, you come up with problems that you have faced. To take a simplistic example, cases of transference, counter-transference, negative transference, all these, not only case material, but process also needs to be discussed. Individual professional experiences need to be discussed, and that does indeed go on in Balint groups. So we'll move on from here, and I will now request Dr. Rathna to speak to us about what is it like to be in a Balint group. Before we do that, I'll introduce Rathna. Rathna is a psychotherapist and a supervisor and a trainer in private practice for over 2 decades. And she is an external consultant to one of the well-known counseling centers in Bangalore, that is the Parivartan. She helps them with their research as well as their training. She is external faculty at the local St. Joseph's College. And very remarkably recently, Rathna is one of the lead authors of a book on reflective practice and professional development in psychotherapy. I will just say one more thing. We will have 3 speakers, or rather 3 components of the first session. Hopefully, we have time for questions and answers after that. If you have any remarks or questions, please post them in the chat box. We will take them up as soon as the 3 speakers are done. Then we have a second session, which I will introduce after the first session is done. Sorry to hold you up, Rathna. Over to you.
Thank you, sir. Let me just share screen so that I can.
Yes, we can see it.
Yeah, is it visible?
Quite visible, yes.
Okay, so you've heard about Balint groups sort of from the outside. So my job here is to kind of describe what it's like from the inside. So let me get started straight away. So this is something that happened a month ago or so, where I'd had a session with a client on one day, and this is a client who was having a very difficult relationship with her daughter. Later that night, she sent me a message saying that the daughter had committed suicide. And just the previous day, we'd had this session where I was like trying to help her to set boundaries in her relationship with her daughter. So when I heard this news that sort of immediately after our session, almost the client has gone home and experienced this was like it was a very big shock for me. And I had to sort of, I don't know, I wasn't really sure what to do. Luckily, that evening we had a Balint session. And as I sort of started talking about that experience, itself was a relief. And then the group started discussing it, and different people said different things, about what I was going through, or what the client might be going through, or what might have actually happened. And so by the end of that session, I felt, for me at the beginning, I was feeling very guilty. I was wondering, like, is this my fault? Have I done something? Have I triggered this? But sort of hearing everybody put the whole story together, it was easier for me to kind of accept what my real responsibility might be. From feeling alone the whole day and wondering what to do, just in hearing everyone else talk about suicide being such a difficult experience, and how it shakes all of us, there was this feeling of being together. From feeling scared, what's going to happen, I think by the end of it, I was able to sort of feel supported and, kind of there's a we'll figure it out feeling. And very usefully, I think, actually from focusing on myself and did I do the right thing? Did I do the wrong thing? What should I do next? What is the client going to throw at me next? which were the sort of things which were going through my mind before. Just hearing everybody speak about this client and her story and what this whole thing might have meant to her, it helped me to kind of refocus on the client itself, which in the next session when I met her was definitely extremely useful. So this is kind of what it's like to be in the group, but to give a small introduction about how this entered my life. So I finished my training in NEMHANS in 2005, where I'd had both individual and couple therapy supervision. Other than that, I've pretty much been in private practice. And while I was seeing a lot of clients, there was no real frame. There was no one to teach you, or there was nobody to kind of bounce ideas off. So, really the learning is from making mistakes and then figuring out what happened. Maybe now and then you could speak with peers. So as a practitioner, I found myself being a supervisor before I'd really been in supervision. So it was during COVID when Dr. Mathew kind of invited me to join this group. And, we had our first meeting in August. At that time, I'd been forced to start working from home. So as it is private practice, you're alone. Working from home, it's like your world becomes even smaller. And I'm sure as all of you remember, the work hours had extended, everyone was feeling isolated, clients were overburdened, they were reeling, I was reeling. It was a really difficult time, I think, especially the first few months of that first lockdown. And I, as a practitioner, was feeling like a really strong need to receive, like, where can I go that, I will feel relieved. I knew some of the group members, having trained with them, like both psychiatrists and clinical psychologists. Some of the others were new, so there was like some sense of familiarity and some sense of newness. At the same time, I must admit, initially I was kind of skeptical and nervous, like nervous because, actually presenting a case and talking about what happened, it was something that I hadn't done for a long time. So that's, what will people think about me? And those worries were coming up. Skeptical because I was wondering, like, what will this group really have to offer me? Will they understand what it's like to be in private practice? I was the only private practitioner who was a sort of full-time therapist in the group. Would they get my setting? So yes, I had my questions about, is this really going to be useful for me? But I knew I needed some help or support at that time. So I said, okay, let's just take the plunge. So like Dr. Mathew said, we would meet twice a month, and it was, it was in the evening. Dr. Arun would send reminders saying that, we will meet today for the session. And that kind of, it made it easy to sort of fit into working life. So I think as like a busy working professional, it kind of, the way in which it's structured was very useful. Each story, whether I was presenting or someone else was presenting, you got something out of it. You sort of came to one conclusion within your own mind and kind of, so each person, I think, actually literally gathered what was meaningful for them out of the discussion. And so we all got our closure in a way and all figured out what we could take forward in working with clients. So I just want to talk about this whole camera off business in Zoom. And, I think, so what you do is you present the case and then you put your camera off while everybody else is discussing it. So one, I think it offered privacy because you can be making your faces and sort of relaxed almost when everybody else was having a discussion. This not being able to talk, but just having to hear what everybody else has to say, I thought was very useful, because my natural instinct, if something is being discussed, I want to jump in and say, no, but you know, it wasn't like that, or this happened, or that happened. And here, because you couldn't do that, you actually had to sit back, listen to what each person was saying, reflect on your experience, maybe reconstruct it. And it was really, I think, useful to be able to do that. And definitely there's a sort of sense of relief of like, okay, now these 10 people are discussing my case and they're going to figure out what to do. So I can relax in a way while other people are doing my work for me. So I really enjoyed that particular part of this balance structure. The facilitation, I think, was really important. Dr. Arun was so skilled at sort of keeping the conversation constructive, you know, keeping it reflective or explorative instead of trying to ask factual questions and trying to narrow it down into, okay, this is right and this is wrong. The group as well, I think, whenever they were discussing a client or a therapist, we were all quite, I think, sensitive to what it's like really to be a mental health professional and the sort of strange situations that we can face as mental health professionals. And that sense of being in this together, I think, is something that felt very good. So while there was this structure, I think there was also a lot of space, because the actual discussion was not kind of monitored. And so each person would just jump in with their own impressions, whichever their strongest impressions were. So sometimes it might be about maybe, you know, what was the diagnosis, or what the therapist might have been feeling, or what the client might have been feeling, or what might have been happening in the relationship. You know, sometimes everybody was trying to talk together, so there was a bit of a cacophony or a high noise level. Sometimes everyone was just quiet, because I think everyone was feeling, I don't really know what to do about this. So this kind of free-flowing conversation, we could keep our professional hats on, take them off also if we wanted to. I think it really, you know, enables you to kind of act like be a professional, but still in a much more relaxed space, and just opens your ideas to new kinds of thoughts. Peer groups, I think, you know, I really felt their values. So having other people who were in somewhat similar settings, seeing similar kinds of clients was useful. We got multiple perspectives. So the group being interdisciplinary, I think, and coming from different kinds of settings, psychiatric hospital or general hospital or private practice and clinic, this also really helped. So there was sort of new information and ideas even as we were speaking to each other. Dissent was definitely more common than agreement. So again, this idea that there are so many different ways to think about an experience, and we don't have to only come to one conclusion. And I think that sort of initial shyness about, can I actually talk about my experiences, it enabled me, and I feel I can say with other group members also that, you know, it was nice to sort of feel seen by your peers and be able to talk more freely about your case. So quickly about how did it help my practice? I feel I learned not just from my own clients, but from everyone else's. Sometimes it felt like a common presentation. Somebody else is talking about a case and you're like, yeah, I recognize this. I've experienced the same thing with my client. Or sometimes you hear what other people have done and it was like a unique solution. You feel like, oh, I wouldn't have thought about that by myself. Whenever I brought in a client, I think I always left feeling a little more clear and having a little more direction about, okay, these are the things that I can try. And, so overall, I feel as I can continue to learn, it aids with professional growth on the whole. It's been 3 years in this Balint group, and I think, we've gone through our ups and downs. People have come, people have left, some have taken sabbaticals. The facilitator, Dr. Arun, just sort of hanging in there and sticking it through some of these ups and downs, I think was very valuable. It, until it kind of became like, yes, a definite thing that every alternate Wednesday, you'll get that message, and then you know that there's a session that evening. I think, at this point, I would say that it's definitely become quite an intrinsic part of my self-care as a therapist. After these years, it's like you feel like, okay, I've found a home, and that is a lovely feeling, which I didn't actually expect at the beginning. So thank you very much for hearing me out. I'll stop share now and we'll get back to the general script. Thank you.
Thank you for a very personal travelogue, I should say, in this journey, of this journey, and for laying your soul bare as a therapist. I think that was very useful, and that's exactly what is necessary in a session like this. I'm sure Rathna's presentation would have provoked some thoughts and questions. Please post your questions in the chat box, and we'll take them up after the third speaker. We now move on to the third speaker for today. What is it like to be in a Balint group, the Balint experience, by Dr. Ashlesha Bagadia. Dr. Ashlesha, just a minute. Ashlesha, you can get your slides going in the meanwhile. I will just introduce you. Dr. Bagadia is a perinatal psychiatrist and psychotherapist working at a foundation which she was instrumental in starting, the Green Oak Initiative, which is a community mental health center in Bangalore. She's trained in psychodynamic therapy, family systems therapy, and group therapy. In India, she's been running a group therapy program for personality disorders, particularly borderline personality disorder, since 5 years, and reflective supervision groups for over 7 years. She's been part of this Balint group for 3 years over here and has applied the principles to other groups of medical practitioners. This was a question raised by Mathew a little earlier, and he did mention that Ashlesha has been doing this. Specialists such as obs-gynae people and non-medical professionals, including school teachers. Now, this is something we need to be aware of, that Balint does not necessarily restrict itself to medical professionals or mental health professionals in that narrow sense. However, it's good to have a homogeneous group in certain contexts and a heterogeneous group in others. But I think we will now hear from Ashlesha. Her brief is what is the Balint experience. Over to you, Ashlesha.
Thank you very much, and I'm delighted to be here today. Sharing my sort of understanding of Balint group and the therapy experience. I was definitely resonating with everything that Rathna was saying, and more. I got introduced to Balint as a trainee in psychiatry. And I remember the early experiences where we would, go because we were supposed to go, and we would grudgingly go, what is this? The psychotherapist is just going to go on about what does this mean for you and things like that. So we expected to be analyzed in some way. And there was a reluctance to get analyzed, I suppose. And then we realized, as you heard from Rathna, and what a Balint group is, that it was not really about us being in the spotlight, but us having a shared experience. So I'm just going to touch a little bit about, what a Balint group looks like, and what are the principles in a Balint group versus a psychotherapy group, and how that is different, and how there might be some similarities as well. So as you heard earlier, in a Balint group, it's a homogeneous group. It started off with, for GPs presenting a case or a patient that they had in their mind, that it was, something that preoccupied them. And in my experience, I've seen that applied to a situation. It could be a student. So even in the group of school teachers that I run this group for, they might bring an interaction with a student. So understanding the patient becomes the starting point, or understanding that student. And it's really a reflection of that interaction, reflection of what I think might be going on. But the uniqueness that Balint group might bring, especially if it's done in the way Dr. Arun was describing and Rathna were describing, where the person who presents then sits back and watches the discussion, really gets to absorb the discussion, the different things that people are reflecting upon, rather than just being asked questions. So if you compare it to a regular, say, a case discussion group or a supervision group, what might end up happening is that the person who's presenting will present a case or talk about a situation, and then it's a discussion with that person. Oh, what did you do? Could you have done this? Shall we look at a different diagnosis? What are the different forms in which we could do it? So it really is a interactive question and answer. What are we going to do next? Let's find a solution. Whereas in Balint group, we are not necessarily looking for a solution. We're not necessarily looking at only talking about the problem. We're just reflecting on all the different things that could come up. So it's a reflection of the interaction. It could be a reflection of self as well. And it's not just the person who's presenting that reflects on the self. It could be the other people as well. So it can be, when I heard that, this is what I experienced, or this is something similar that I've experienced. And in that discussion, it becomes a shared understanding. Sometimes even the, not being able to share or not being able to understand, it looks like you're all focusing on this particular person, whereas I seem to only want to think of the other person. And I'll share an example of a case, and I thought it'd be good to compare it to how it might look different in a therapy situation. So I had brought this couple that I've been working with, and there are two people in the room that I work with, and I wasn't bringing this for a supervision of couples therapy. I wasn't bringing in for tell me what to do next. I was just thinking about what is going on for me when I'm dealing with this couple, and what do other people think about this couple. And in the group, there was some discussion around, it looks like these are their struggles. It looks like he sounds like he's like this, the husband. The wife sounds like he's like this, she's like this. What actually stood out for me was that some of the dilemmas that I was having were reflected on what everyone else was sharing. And even though I was feeling like I have to understand in a certain way, even in the group, there were differences in how everyone was understanding it. Some people were more aligned, like, we need to think about the husband. Why are you not thinking about the husband? And some people were more aligned with the wife. And most of the group was also saying that let's look at them as a couple. Let's think about what's happening here. So I feel even if there is a recognition of, okay, everyone is understanding a certain way and I'm understanding differently, that also can be a very useful experience. So in a Balint group, there is a room for discussion and experiencing the patient, the case that you're bringing, and what the case does to you as a person, or in that interaction, what it did to you. Of course, it is not a therapy group, which means that you may not, as a participant, have to share, oh, this was something I experienced in my childhood, that's why it's very difficult for me. Although in many Balint groups, when people start feeling comfortable enough, they do share that. But it is not going to follow that track. It's not going to be a space where you then start turning it into your own therapy. It still remains very much focused on the case or the student that you brought for discussion. And in that way, it can be quite protective because it is a professional group. It's a professional group where we are still professionals working together as colleagues, and not feeling like, okay, we have to share some really personal stuff because it is not a therapy space for you. But I've also experienced this myself, and I'm sure that you'll hear this from other people, that the experience can be therapeutic. Because sometimes, most of the times, what I've noticed as clinicians we tend to do is we are going to be more hard on ourselves when things are not going well. Especially if you're bringing a case for discussion that we're struggling with, we're most likely thinking, I'm not doing a good job. I've just got this all wrong. And this is terrible. And even like Rathna mentioned, there is a little bit of apprehension or, tentativeness. Should I share this? The tentativeness comes sometimes because we are worried about us not having done a good job. And when you start listening to the reflections of everyone, because they're not telling you, why didn't you do this? They're more like, oh, what's going on here? I experienced something similar. Not only do you realize things that you may not have realized, but you also start realizing things that you've done well. And that can be very validating. That can be very therapeutic without necessarily it being the intention. So it doesn't start off that we are going to make you feel good or we are going to make you suffer less. Whereas in a psychotherapy group, that is a premise. You come for therapy because whatever difficulties you're struggling with, you're going to hopefully overcome them. In Balint group, that's not necessarily the premise that you are going to fix your problems. We're not saying that in a Balint group. We're saying this sharing is going to change something. It's going to make you a little bit more reflective, make you more observant of the things that you may not be doing well, but more importantly, make you more observant of things that you were already doing well or had reflected on, but thought that, no one understood that. So that shared understanding, that experience of understanding the patient or the client or the problem in the context of other people. That is one of the main experiences that comes with the Balint group. So if you think about this, and we can also have this in a discussion if people have questions, when we compare it to a psychotherapy group, I've been running a group, as mentioned, like a psychotherapy group for patients with personality disorder for a good 5 years now. And that is a little bit structured group where we have a proper contract that you have to enroll for this limited period of time. So often psychotherapy groups, especially if they're structured, if they're very skill-based or they have a very clear, either a diagnosis or intervention that we are going to intervene. So for example, a loose psychotherapy group is like the groups that you would have heard of in Alcoholics Anonymous, which is a form of a psychotherapy group. In that psychotherapy group, there is an understanding that you are coming because you have some personal difficulty and you're going to engage with a group of people whom you may not be working with. And often the psychotherapy group is not, in fact, in many groups, it is recommended that they're not known to each other personally. So or in a working relationship either. So the people coming into the psychotherapy group are usually not known to each other in a working capacity or in a personal capacity, and they are bringing anything. They need not bring obviously a situation, but they could bring a situation. They could bring an interaction. They could bring a dream. They could bring whatever is on their mind. And the similar thing that happen is there is a reflection of the interaction. There's a reflection of the self. There is shared understanding, but also there are exploration of unconscious processes. There are exploration of what's happening in this group. When someone says something, someone else gets annoyed. What happened there? What was making this person annoyed? So there is a straightaway, in a psychotherapy group, we are going into the relational processes. We're looking at what's helping this person speak up, what's keeping someone else quiet. So in a psychotherapy group, we are moving beyond the situation itself, and we're going deeper into the personal narratives of the people who are presenting. And sometimes, and sometimes it need not even be a situation. Sometimes, like Rathna said, sometimes the groups are loud and everyone wants to speak. And something very similar can happen in a psychotherapy group where they can be loud, and there can be a lot of people want to speak, but they're also not necessarily holding back in their personal opinions of each other. And they may or may not have the skill to share it in a non-judgmental way. And the facilitator's job is to get a little bit more insight, to really get into the, what's happening for this group, what's happening to each one of you as you are sharing, what's happening to you when you go away from this group. So a lot of the conversation or discussion is brought to the center. Whereas in Balint group, I might go away and think a lot about what happened, but it may not be something that we share in the group itself. In a psychotherapy group, that's also brought to the forefront. What are you doing in the group? How do you apply this outside? What's the week like for you after you come to the group, or if you don't come to the group? So in a psychotherapy group, it definitely gets into the personal narratives of the person. Whereas in a Balint group, it stays in the professional space. But the added benefits of us reflecting on our own unconscious processes can happen without even realizing that it's happening. As you were listening to, Dr. Arun and Dr. Mathew talking about just needing a reflective space, that is something that has been there in the psychotherapy framework for a long time, but it's not talked about it in that sense. And I think the Balint group came when the whole psychoanalytical life was in crisis, that people were questioning, do we really need these psychoanalysis spaces? So the Balint group came as a professional space, a reflective space, and psychotherapy also can be reflective. And the more and more psychotherapy groups are becoming, not just skill, we're not just giving you what to do, but we're also asking to reflect. So these are some of the main differences between these two groups. And the kind of common things that can happen is that different versions have evolved over time. I can see that the group that I run for Balint style group that I run for teachers is slightly different than the one that I run for the obstetricians. And the therapy groups also have evolved over time. But there is a clear distinction between the two. And if people have any questions, we can definitely talk more about it. But I hope this gives a little overview of what's the difference between a Balint experience and a psychotherapy experience. Thank you for that.
It does indeed, Ashlesha. Thank you very much for your inputs on the brief given to you. Fairly adequately and fairly addressed. We've now come to the end of 3 important presentations, and we have a few questions that have come up. We are running slightly behind schedule. We will take up the questions that are there. Some of the questions have come directly to me, but I would address them to the group. The first question that came up in this context was from Vandana Shetty. Arun, I'd like you to please take this up. How is the Balint group different from peer supervision? Would it also include discussions about pharmacotherapy if the client is on medical treatment? And related to this, there was a question from Nimisha Desai. Any scope for discussing psychopharmacology, or is this only for process or therapy? I took the liberty of answering that by saying this is a psychotherapy-based program, definitely not a pharmacotherapy one. But there are dynamics involved in pharmacotherapy, which I think sometimes need to be brought up. Arun?
Certainly. Just to add to that a bit about, do we discuss psychopharmacology? We've got lots of spaces to discuss psychopharmacology, so we don't necessarily
Too many.
Yeah, but we do, in a sense that in a Balint group, we might talk about medication, but we talk about things like compliance. We talk about resistance to sort of treatment, but we might not discuss a particular drug. Sorry, Ajit, the other question was about reflecting.
Balint group different from peer supervision.
Oh, yes. So I think the question here is about, supervision can occur either if it's psychotherapy supervision, then it becomes a specific thing based upon, cases, and it becomes between the therapist and the patient. And that takes a sort of a situation which is dissimilar from a Balint group because it's not focused upon one particular case. But I think the question that's being asked is, can people in a team come together to supervise each other in terms of their practice, I think that's something similar to what we might call a staff support group, where you're examining your practice. You're also talking about whether the theoretical aspects of or the processes that are being followed are actually useful or not. So I think peer supervision groups are again dissimilar from a Balint group in that there isn't a particular case, but the focus is on the practice.
Thank you. There is another question which I think I should address to Ashlesha, which is being in a medical college, I'd like to know more about Balint with medical students, residents, and so forth.
Yeah, that's actually a very good space to introduce Balint group. We are doing it with obstetricians. Again, it's a hit and miss. Getting them on time is a problem. Sivakami will be talking a little bit more about the Balint group that she's been running in institution. And if people are interested in running a Balint group with the medical students and residents, then definitely get in touch with us. I think it would be a very good space to introduce a Balint group. In fact, I feel like, striking them early, like as medical students, will be a great place to do because, we are not already molded into only thinking in solution-based ways. And we don't only want to diagnose and treat and diagnose and treat. So getting them to start reflecting early on would be a great thing to do. So yeah, I think if we are able to, if people are interested in running it in a medical college, then we'd be happy to talk more about it.
So the basic answer is yes, it can be done. And
Ajit,
do you suggest that levels of seniority matter? For example, fresh medical students and then clinical medical students and then interns, postgraduates. How does that make a difference?
So I maybe others can also answer. I feel like the biggest barrier is the logistics, and that becomes the what matters. So often you'll find that the homogeneity of the group is decided by who can attend and at what time. So you're more likely to get medical students together because their timetable is matching rather than the interns coming with the other groups. So we actually try to do this at St. John's, and just getting groups of people together in a different time frames is very difficult. So often it becomes about logistics. And I don't think it matters if in terms of seniority for the group itself. But I think because of logistics wise, it's actually better to have medical students together, and they may be more comfortable if they are a more homogeneous group. But maybe Sivakami can, I don't know if you want to ask her to respond.
She's going to come up in the next session. So
could I add?
Of course.
So in the UK, we've been running groups for medical students for the last 5 years. So if I can start with why, as doctors, we are taught to be very objective. So being objective means you don't think about yourself, you only think about the patient, and sometimes you think of the patient as being an object. Now, this is the theory, but when you come down to practice, it's very messy because you realize that you are in the room and the patient is in the room and the two bodies interact. And that brings about, I think, lots of stress. There, I think Balint groups introduced to students will help them to realize what that messy feeling is and how to deal with it. The second thing I think is that's useful is for medical students to start thinking about the system of medicine, the practice of medicine, the patient, and then themselves, and their place in that system, in a team or otherwise. So I think we should start with medical students. And I wish more medical colleges would take it up in India.
Right. Mathew, you mentioned post-COVID, how the group got dynamic and so forth. I want to ask you a question which has been addressed in different contexts, but the basic question is between having face-to-face interactions and having online interactions. In the context of Balint groups, what difference does this have? And have you had Balint groups face-to-face as well?
Yeah, very interesting, Ajit, because when I was preparing for this, I was watching a YouTube video, a discussion between 4 or 5 therapists, done way back in, I think, 20 or 21. This is from the American Balint group. They were talking about how to convert your group into an online group. And in those days, you know, when in the early days of Zoom, they were talking about so many issues of confidentiality, which platform is better, is Zoom better, is Teams better, and then the kind of how do you ensure the same kind of participation in a Zoom meeting as opposed to an in-person meeting. See, I started off a sort of Balint-like group at Nimans before I left. Before even Arun and I started this group. And I remember the challenge there was, Ashlesha will know, that was getting everybody together on an evening at 5 o'clock, beating the traffic and getting together. But I have tried to run many of my psychotherapy groups in the kind of quasi format of Balint. And there is, of course, a difference. For example, in this discussion on what happens on Zoom or online, the usual practice is that everybody keeps their videos on, so you know exactly what the other person is doing. But if you put your video off, you could be doodling, you could be talking to somebody else, you could be, you have gone to make dinner or whatever, So it's good to keep things on, and then there are some advantages and disadvantages for the leader and also the co-leader, because the leader and co-leader can actually talk to each other on a Zoom, on chat, and say, you're doing this or you're doing that, or this is happening or that's happening. And that's something that is very easily done on Zoom rather than face-to-face interaction. But there are, I think you cannot take away the sort of excitement, the involvement, the sort of, group feeling that you have in a face-to-face interaction. That's very different. But what these people are saying from the American Balint Society was that it was possible to engage very well with people even on a sort of video platform.
Right. Rathna, would you expand a little on the evolution? Because one thing that struck me, I got a sort of red alert when you said there used to be cacophony. Somehow I've never encountered with cacophony. Maybe I joined later, by which time the group had evolved sufficiently to dissipate that kind of interaction. You did mention that everybody gets into participation, and I would presume that that's how the cacophony in the first place arises, because we are not basically ruffians. So would you like to elaborate on how you would think of streamlining it so that such occurrences are avoided?
Firstly, I think when, it's just that when the question is put out, what do you think about this? Everybody has been sitting and thinking about this, and then we're all ready to speak or all ready to start saying something. And it took us some time, actually, and it's nice that you put it like that, to kind of figure out what do we do. So first we thought, okay, if you want to speak, you do the raise hand gesture, then we know that it's your turn to speak. How do we figure this out? And when I look back and think about it now, I think just very organically and interpersonally, that whole thing just started when one person started speaking, everyone else paused and waited for them to finish. We didn't really have to do anything very consciously or specifically for that. So I think it's like just about learning to maybe be in a group. So the facilitator, of course, does help a little bit in kind of redirecting, what is the content? Or shall we look at this, or someone else? Okay, also you look like you have something to say, kind of thing. So I think the role of the facilitator and sort of keeping it going around is very useful here. But really, more than anything else, it's just our familiarity with each other and with the setting that, shifted that a little. I also want to say that I don't necessarily think about the cacophony as a negative.
Exactly.
Because
I thought I implied that in the question also, because
actually,
it shows enthusiasm.
yes, and everybody does have sort of something to say. And so everybody says their first thing, and then we all stop and think about it. And by the end of the session itself, it quietens down naturally.
I like the fact that, at least as far as I've seen it, the facilitator, as you call him, moderator, chair, whatever we call him, is really, this is said very cynically at times, but this really is not cynical. First among equals. I think both Arun and Mathew have fulfilled that part of it, because there is no clear hierarchy except for monitoring the process and seeing that things flow smoothly. I think that's a tremendous advantage when you have a Balint group of the kind we do. Arun has answered the question, nevertheless, for the general public, for all our participants. Is this a closed or open group? Again, from Vandana. Arun, you've typed an answer. Could you please repeat it or elaborate on that?
Yes. So the way I answered it, and I'll welcome the others to comment as well, is I call this a slow open group. In that, some people need to take a break and then they go off, or some people take a sabbatical, some people leave, and then new people join. So to sustain the group, we add people as and when needed. We've kept the total at around 18. And I think at a given session, we have about 8 or 10 attend. So that's the way the group runs.
My limited experience with this over the last 19 months that I have been with the group has been that we almost invariably discuss cases. A little more about that later. But we've never really got down to actually discussing processes in a theoretical fashion, which I understand happens in some Balint groups. For example, how do you deal with my favorite topic, countertransference, or how do you deal with negative transference? Is this something which can be taken up as such?
Ajit, interestingly, we don't do it now, but in the past, what we've done is sometimes we've just had open reflective sessions where we don't talk about a case, but we just reflect on something that might be happening. For example, in one session, I think we spoke about, how long does one see a case in psychotherapy, and why? That was one of the questions we spoke about. And in another, we spoke about, how do you feel when a patient is, you don't like a patient, and what do you do with that feeling? So we've had open reflective sessions, but fewer now.
Yeah, but if you see, Arun, we have had those discussions when there are only 3 or 4 of us, and we didn't really, in that sense, start a group.
True.
But I think invariably it is basically discussing the client therapist interaction, really, and not, so I guess Ajit's question is more like what Ashlesha answered in terms of psychotherapy discussion or psychotherapy supervisory processes. That's a little different from Balint groups, I think. But
so I want to just step in to say, I think that we do actually most of the time end up discussing countertransference or your feelings towards the client. It just happens in the context of a particular case. And in a way, it's kind of useful, I think, and grounding to discuss it in the context of a case, because then it really stays tied to the experience. Otherwise, these things can just become intellectual discussions, which, so I find in a way this way of approaching your feelings in the session to be actually quite useful. So I just want, I don't see them as either this or that in a way. And
okay, that's your take. I do feel that we should discuss processes by themselves, not necessarily in the context of a given case. But what you say is very true, that given in the context of a case, these issues do come up and get discussed. One great thing is that There is no priming, there is no agenda. Anybody in the group can come up with a case. That spontaneity, I think, was something that baffled me in the beginning, but has made a lot of sense as I've gone along with the group. Are there any questions? Anybody would like to raise their hand and ask a question, or just indicate to me that you'd like to ask a question? Otherwise, we move on to our next session. We are in good Indian sliding time, just 15 minutes behind schedule. All right, so we've looked at what Balint groups are about. We've looked at what overlaps are there, and there certainly are, between group therapy and Balint therapy, peer supervision, and reflective groups in general, of which Balint is a particular kind. We've also looked at what Balint groups are not. We've had a veteran share with us a voyage through the process of a Balint group, and I think all this enriches us. I must confess that there has to be, invariably in this kind of a meeting, some degree of overlap between the speakers. In fact, there was a considerable overlap in all the speakers this time, but all of it was very useful. I would not consider it as redundant in any fashion. We'll now move on to the second session, which has three speakers, Dr. Sivakami, Dr. Sabina, and Dr. Priya. I will introduce them one by one. And we're looking at leading a Balint group. How did being in this group change my professional perspective? And how did being in a Balint group help me deal with professional stress? So I'd like to invite Dr. Sivakami. Just 1 minute, Sivakami. I'm going to introduce you very shortly. Dr. Sivakami, though a recent entrant to our group, has been a veteran in the field of Balint groups. She's a consultant psychiatrist and psychotherapist working in Chennai. She runs a psychotherapy service for adults and adolescents. I don't know whether those are together or separate. I presume they're separate. She has been running a Balint group for postgraduate trainees. And this is again related to medical students in a sense, in psychiatry at the Institute of Mental Health over the past 3 years. She's been very modest in giving me a very brief biodata. Over to you, Sivakami, to speak to us about my experience in leading a Balint group.
Right. Thank you, sir. So I'll just share my screen and get started with my talk. Right. So I'm going to say a bit about my experience of leading a Balint group. The objectives of this talk. Sorry, I'll just play the.
Yeah, share.
Yeah. So the objectives of this talk. So I'm just going to say a bit about the Balint groups that have developed in the Institute of Mental Health, Chennai over the past 2 years. When I was preparing the talk, I was just thinking about the 2 years and how it has been. At the same time, I also found the Balint, there is an evaluation form. So I thrive on structure. So I found the Balint leader evaluation form as a good tool to reflect on my experience. And I also have some thoughts and feedback from the members in the group, from some of the trainees. So I look forward to saying a bit about that, sharing some of that also. Right. So the setting, I'll say a bit about the setting. A lot of you here may already be familiar with the Institute of Mental Health, which is a tertiary care mental health facility, a public funded hospital in Chennai. It is a teaching hospital with postgraduate trainee doctors, approximately 50 of them at a time, although it has been more chaotic at this point in time, owing to a lot of fluctuations in admission and so on. And I thought I'll just say a bit about the setting, because then it might bring to life what this group actually looks like. And so the PGs form the backbone of this hospital system, carrying out, as in many other centers, carrying out majority of the clinical work under the supervision of more senior doctors. And they already have very sort of somewhat robust regular clinical teaching and supervision in place, with weekly programs to support this. So we introduced a concept like the Balint group or an experience like the Balint group in this setting. We started in around December 2021, and the groups are weekly. The timing, so we have an hour like in traditional groups, Balint groups, and the hour we've managed to keep it consistent in the same time every week, which was a challenge in itself. However, we've been able to have that protected space. The group comprises of PG trainees from years 1, 2, and 3. So in this hospital, doctors and trainee doctors work together in smaller groups called units. And so we started to meet one unit each week, with units taking turns. So people will get to attend once in 4 weeks or 6 weeks, that way, actually 6 weeks. And therefore, as you can already see, compared to some of other settings, there was an element of flexibility that was required even from the beginning. So with regards to attendance, so we've had group sizes ranging from sometimes 2 people attending to sometimes 6. I think we've had a maximum of 8. So it's quite variable. Various factors affect attendance, like workload in the hospital, availability of PG trainees in the main center, because they could be posted in other places as well, and number of trainees enrolled at any given point in time. So that also affects the PG's personal bandwidth to engage with something like this. So I have never trained formally as a Balint leader. So I'm a psychiatrist and I'm also a trained psychotherapist. And I started, when I initially started, I started using that model just for myself to reflect on the doctor-patient or caregiver relationship. And I think it was 6 months or a bit more into running the group, maybe a year, that I joined this group. And I've also been part of Balint groups in my time as a postgraduate trainee in the UK. So with all this, with this sort of an experience, I started the group. So in the group, I follow the typical Balint group method, which has been talked about by others just now. And so I try to, so we come together as a group, we invite someone to share a particular experience or in an interaction. And we are a bit open to interactions, not only with patients, but also with caregivers, because that is a huge theme in this setting, where a lot of work is done with caregivers. So that interaction between the clinician and the caregiver is also looked at. And so this was probably more in the earlier stages. Sometimes I do say some things explicitly, where sort of to bring in, like, to enable people to maybe assume a different role from what they may be used to. So for example, to speak to the group as opposed to present to the leader, which was a very natural stance that a lot of the trainees were taking. And then to encourage to speak outside the typical case presentation format. So these are things I don't know whether these are done, and I assume they're not in the usual Balint groups, but in the initial stages, I did sort of bring in some explicit guidance in that sense, but a lot of it wasn't necessary because we were able to get into a specific way of interacting quite soon in our time together. And attending Dr. Arun's Balint supervision group started becoming an important exercise for me to become more confident with the method. So now I'll say a bit about what it's been like. So I think in the early stages, like somebody else mentioned about how groups evolve, I think there was a lot of uncertainty, and a lot of it was also emerging from my own inexperience of having never done something like this, maybe under supervision. So it was not a task that I had trained explicitly for. And one interesting thing that came up, maybe a recurrent phenomenon, was like where I found myself gently pushing back to stay away from entering into discussions around diagnosis, management, sort of, tell me what to do next. And that there was a push and pull, which is quite uncommon at this point in time, but was a presence earlier in our group. And I'm just picking up some aspects from the evaluation form just to, just think about these specific aspects. So one thing that Balint generally look at is sitting comfortably with uncertainty, or becoming comfortable with uncertainty. And so gradually, I think we've all been able to come together and start staying with difficult situations that didn't have straightforward solutions. And a trend emerged where trainees were bringing in scenarios which were more difficult. So Ashlesha was thinking about how if somebody is bringing a situation, then it already is probably impactful or complex in a certain way. So trainees just naturally started bringing in such scenarios. And this dealing with uncertainty, becoming okay with it, was a significant experience in itself, considering the traditional doctor-patient relationship, where the doctor is expected to bring in a high level of certainty. And I think both Ashlesha and Rathna, they were talking about coming together as a group and building a shared experience. And I think sharing this uncertainty as a group did emerge as a significant thing for us. And it's also been quite rewarding for me to see how trainees can be very generous with one another, especially in difficult situations.
Not my Bluetooth my charge nahi.
I'm just someone's.
Can the others mute? Some people are.
Can you mute yourself, please?
Thank you. So the other thing I thought I can think about is how we started elaborating, reflecting, and clarifying feelings. So I was thinking of what Ashlesha was saying about, going in as a trainee doctor who hasn't probably experienced something like this ever before, and kind of being like, what is this, therapist going to do kind of thing. I think that was certainly something that was prevalent in the groups, especially early on. So something about, what is happening to me in this interaction, or what is happening to me in my professional role. So having those boundaries and becoming comfortable with finding words to reflect on that, and then to express that in a group. All of this was a very gradual development, and it came up with great reluctance, especially to enter any state, especially like, experiencing fear or anger towards the patient, other than anything that is generally approved in a traditional role of a doctor. So, and I think at some point, humor has entered groups. Humor has supported some of these reflections. And by now, it's as if there is a trust. And this is passed on to those joining for the first time as well. So it's like a collective trust that has grown. But this has been one of the key things that I think that has gained emphasis in our groups, to be able to wonder about, okay, what was happening for me in that interaction. The other thing I chose to think about was to link happenings in the group with events in the scenario that was being presented to facilitate understanding in the group. So again, this was something that was slow to emerge. Also, I think on my side, attending the Balint supervision groups was very useful in becoming more aware of my own movements and responses to the group. So I was positioned more comfortably to speak up, bring up things that were happening in the group in the present. So that was a development that I register. And for instance, I remember sharing an experience in our supervision group about maybe a time when I readily fell into a teaching role without being able to think about, what might be going on in that moment for that trainee, or in that scenario, or in the group. So I think this is another aspect that we have experienced. And I think this is the last one I'm talking about. So about assuming different roles. So I think being a Balint leader, possibly one wears different hats. and it's a dynamic thing as well. And when you're relating, in my case, when I am relating with trainees, it sometimes there's a pull to be a teacher. At the same time, so this one has been a bit challenging. So sometimes the whole discussion starts with how to do psychotherapy for this patient, that sort of a thing. And or there's a clinical dilemma that just needs to be addressed and where we cannot just sit, kind of thing. So maybe tracking myself as to where I seem to be moving has been necessary in becoming comfortable with kind of waiting or kind of not really giving concrete answers and so on. Yeah, so those are some of the points I thought I'll think about in terms of my experience as a Balint leader. The other, I don't know if this is a unique thing in our group, but something that I found interesting, I thought I'll share, was about how we've also been able to acknowledge the system more around the group. So as a leader, I think that was something that I needed to pay attention to. And it was almost like there was an inside-outside divide that was emerging. So the Balint group space was becoming something, and then there's the outside. So sometimes we've had challenges like, yeah, it's okay to slow down and all that. But what about, do you have any idea how many people I have to see in 10 minutes? How many people I have to review? So we've been able to find a way to, so the pressure of the workload and lack of space to be reflective, we've been able to find a way to acknowledge this and speak about this. And we've become comfortable with limitations and also to develop within limitations and so on. And we've also had very good support from the seniors there. And by now it's a stable space. So this is some feedback from trainees. So a lot of them have, so this is just some initial bits I started collecting for a project, which I haven't completed, but yeah, I thought I can share some of it. So it seems to be a largely useful experience for trainees, and with a lot of them finding that they're able to talk about what's going on for them.
Sivakami, we have to wind up soon.
Yes, I think I'm nearly at the end of it. Do I have a minute?
Yeah.
Yeah. So yeah, with regards to being connected with the group process, that seems to be emerging. Trust. So we've been able to cultivate a climate of trust. These are some specific things. Maybe I'll just skip this and say a little bit about challenges before I stop. So there certainly has been many challenges. And it's been important to stay with what is possible and not inadvertently challenge trainees who are already engaging with multiple challenges. And to be aware that this activity can be exposing and building safety is key. And this is not mandatory in their curriculum. So it's remarkable that there is an ongoing interest. So with future, like in many psychiatry trainings, Balint groups can lead to psychotherapy, gaining skills in psychotherapy and so on. We also want to do those things. It's not really happening right now, but we're being quite realistic and celebrating whatever we have achieved so far. I think that's the end of my talk. Thank you.
Thank you, Sivakami. That was quite exhaustive and covered well the brief given to you, your role as a Balint leader, and your confession that you're not formally a leader, but I reckon that whatever's happening has been excellent leadership. But let's move on now. Our next presentation is by our friend Dr. Sabina Rao. Sabina is a consultant adult psychiatrist practicing in Bangalore at a secondary care hospital and a tertiary care setup as well. She's been a part of the group led by, started by Arun and Mathew for the past 3 years. That's right from the beginning. And Sabina is going to address this very important issue. How did being in this group change my practice? Over to you, Sabina. Unmute.
Yeah, thanks, Dr. Bhide. Thanks for having me. Good morning, everyone. So I don't have a PPT. I will briefly talk about my experience.
No, that was not mandatory at all, Sabina.
Yes, I know. So I don't have a long presentation. It's a short one. I'll just read it out, and because it's just my experience, so I will just read it out. So funnily enough, I work at a relatively large multi-speciality hospital. And then this other small setup where there is no admission. It's just a set of OPDs. So for the most part, it's a solo practice. I get some interns in psychology who float in and out of my setup. Sometimes they are masters in psychology, or I've had a couple of kids come by to see what psychology is like. So very few come, and so essentially it's a quiet, easy practice. Nothing exciting happening other than patients. So I'm on my own. I make my own formulations. I treat as I know how to treat for years. I use what I've always learned. I use my training, and I'm a part of a large number. I mean, the usual American Psychiatric Association, Indian Psychiatric Association, but the key word for my assessments and my formulations is a medication-centric sort of approach. So most of my discussions when I attend these organization discussions is medication-centric. So, and there will be a discussion or two on therapy and therapy-driven assessments, but those would be few and far between. So even though I'm trained in CBT, I'm trained in DBT, I'm trained in emotion-focused therapy, I've even trained in eating disorders, I've really not used them much, especially in India. And my passion has anyway always been severe mental illness, so I've focused on it, I've enjoyed it, and I've always enjoyed the art of medicine as an actual use of medicine. So, and then when I moved to India, the nature of psychiatry for me, at least in my experience, the way it is, you sometime over time that you practice, you land up seeing a lot more complex cases. So when challenges cases come along, or I go back to thinking about the way I've trained, I go back into cases and discussions I've had over the years, and then I formulate and I treat easy. So in the past, at least before the start of joining the Balint group 3 years ago, I didn't get a chance to present a case, at least since my training, and I didn't get a chance to discuss, difficult aspects with anyone in my field. So therefore, discuss it with no one. Let's say a case of ongoing trauma or anything. So I just think about it in my head, or discuss it maybe with a therapist who's co-treating the case naturally. So other than that, I didn't quite have the chance. But after joining the Balint, for me as a practitioner in solo practice, it's been amazing, because I can say that in one particular case that I presented. So this was these group of people that I was doing my Balint with, which we meet every 2 weeks. I presented a case, and I presented a case, and I brought to the attention a complex case, a very complex case. The group brought to my attention that, and the group may even remember the case, is that the particular individual had possibly created a shrine of the person they had lost at home, and what that would mean for the prognosis, or one would say the evolution of her, loss, and whether she would actually maybe come out of her loss, and what are the chances that she would actually get better and show improvement and be able to move on. So that, even though I had been talking about it and thinking about it, and she'd been talking about it for a while, it didn't strike me as a shrine. And that word itself made a huge difference to my thinking about this individual and her loss. So that was one case that was amazingly helpful, a tough case for me. Then I had this other case that I wanted to bring to your attention, is a case where they brought to an attention where, again, this was a case, and it was not like I brought these cases back to back. It was between many other cases that were presented by the group. Other individuals, other therapists brought in groups, brought in a case. This was a case I brought in later on.
I urge all non-speakers other than myself to please mute yourselves.
Another time, the group brought to my attention a case, which I brought the case, and it was brought to my attention that, again, a thought that hadn't occurred to me was that maybe a family member was also a victim in the family dynamic. The patient was, of course, traumatized or was struggling with whatever illness they were struggling with, but there was maybe a parent that was also maybe a victim in the dynamic of the family, which again, something I had not considered, which obviously flipped the dynamic of how I would handle the case and how I would approach the patient. And then I would consider maybe, hey, would you like to think about family therapy? Would you consider something else for your parents and things like that? So again, a huge change in how I would approach this young patient of mine and how I would approach many things about the case. And again, once a lot of y'all have been in practice for a long time, easy cases don't come anymore. You get difficult cases and you're struggling. In private practice, not everyone has the luxury of having teams with them. So for me, these two, when I think about, I've presented several cases, not several, maybe 4 or 5 at least, that have been hard. And I think I've had great insight. With these insights, what these insights did for me was give me a sort of new direction, a new lead to explore further. With these insights, I was able to open new venues of discussions, explore areas that were raw, yet critical for recovery of my patient that had presented to me. I have presented difficult cases. I know 30% improvement for such individuals is huge. I know with these Balint group discussions, my patients were able to make the progress. 30% in scheme of things may not sound a lot, but for individuals who have struggled, who are on the verge of significant bad decisions or bad outcomes, 30% is, I think, makes a difference between life and death. So for me, these groups have made that kind of difference. So that's my take on how Balint has helped me. So thank you.
Thanks. Thank you, Sabina. Thank you for illustrating this, as some of the preceding speakers have also done, with specific cases that really drive home the point about your personal evolution as a therapist, and sharing with us the growth that occurs in the course of your participating in such a group. May I now call upon Priya. Priya, thank you for being here. I know you had a little problem getting in, but now you're here, and we're glad to have you here. Priya Sreedharan is a professor of psychiatry and also a psychotherapist at St. John's Medical College. She's the head of a unit in clinical practice as well as teaching in psychotherapy to budding mental health professionals. And she has been a part of this group for the past 3 years. How did being in a Balint group help me deal with professional stress? This is an aspect we have not yet as such dealt with, though it has been mentioned in passing by other speakers. Over to you, Priya.
Thank you so much for having me here. Just a minute, I'm just trying to share my PPT. Okay, I'm a little, I think I will avoid sharing and I will discuss it directly. Is that fine?
Yeah, whatever suits you.
Yeah. So, all right. So just before me, Sivakami and Sabina spoke about how their experience was leading a Balint group, as well as, in terms of changing in the practice. What I will discuss really is what has been my experience in terms of dealing with professional stress. So I would like to focus on 3 specific points. One is the context of me joining in this group. The second point is what I learned and what I didn't learn. And the third is what were the benefits and what were the benefits that I got from this group and what I do feel will translate it if, these other people who are practicing therapy could get into this group. So in terms of context, my reasons for joining this group, as Dr. Arun also had mentioned before, this group was started just round about the time of the lockdown, during the time of the first wave. So as Dr. Ajit had already mentioned, I work in St. John's Medical College. So at that point of time, we were amongst the initial medical colleges in Bangalore in the first wave to be selected for the nodal centers for COVID care. So we were looking at a lot of our resources from mental health being diverted to COVID care, or a lot of our doctors were getting diverted to COVID care. A lot of even our technicians, our nursing staff were getting directed to COVID care. On one hand, we were learning new protocols for how to manage COVID patients. On the other hand, we were also being asked to deal with potential burnout, potential stress that would happen in doctors who were dealing with a pandemic, because that way St. John's is a very good institution. They have a lot of foresight in all these aspects. They do try to work on burnout simultaneously when they're doing new initiatives. So when I joined the group, my reasons were for hoping that, if we are going to run such groups, the responsibility is going to come to the Department of Psychiatry. I'm going to be one of the consultants in charge. So I need some expertise in terms of how to run these groups. Prior to that, although I was doing a lot of individual therapy and supervising psychotherapy as part of group sessions, I really didn't have much experience in terms of doing formal group therapy. And my expectations were similar, learning about, how is it that medical professionals and mental health professionals work in such scenarios, to see if something like that came up. Those were my expectations, but I actually didn't have major expectations. I just wanted to see what would happen really from that group at that point of time. What I learned was, I think, as Dr. Arun has pointed out, and although it's been repeated several times, it's very important that a Balint group really doesn't focus on a solution towards a patient care or solution towards therapy. And although it uses the techniques of reflection, it's not totally reflective also. So what I learned and what I would expect new joinees who join into a Balint group to learn would be that there is definitely an element of reflection towards how therapy experiences go. And that is something that I learned a lot, because what I really got in the group was a lot of exposure to variety of therapies. Like, on one hand, you have people who are exclusively in private practice, as a psychiatrist in private practice. Then you have therapists who are exclusively doing a particular kind of therapy. Then you have therapists who, because they are in private practice, they are more working towards client care, and they may not really have the luxury to stick to a particular therapy. The goals may be different. Then there were other people from other institutions where they were primarily focused on training in therapy. So each time a case came about, as Dr. Arun, as Dr. Mathew had pointed out, the way the Balint group is structured, the way it forms, one was we saw that there were a lot of cases and we saw the variety of difficulties, but a lot of these cases, a lot of varieties of these difficulties, what I also saw was the challenges that happened. How did people go about towards these challenges? And the variety of viewpoints, like as Rathna had pointed out in her initial presentation, dissent is almost the norm. And this was very educational for me. I would put that as the word, that it's okay to have different perspectives, because even despite being part of a team, St. John's has been very fortunate that we have a lot of clinical psychologists of different schools. We do have fairly good, robust discussions in academics. But by virtue of us being a training institution, we do have to focus on the schools of therapies and the principles. But here, because we had a diverse group, it was very illuminating the way it went about. So a crucial thing that I learned really from this group that helped me deal with the professional stress was that in the end, a significant aspect of my stress in my profession, that is, although I'm in St. John's and although I'm working with teaching, is I do a significant amount of practice with patients, is my responses towards the patient. That played a major role. So that was something that's, by being part of the group, not in an explicit manner, but I learned that my responses seem to be affecting the way I go about therapy, the way I go about my interactions with the client. And by probably just observing them, it made it much easier for me. The second aspect that I really learned was that eventually we need to go with the flow. That while we can plan a particular outcome and we can hope for a particular outcome and a prognosis at the end of time, we have to go with the flow. Some people recover faster, some people take a longer time. Someone with psychosis may recover in 4 weeks, and someone with panic disorder may still not have achieved remission in 6 months. And it's okay, and we don't really need to take on that strain of it. What I didn't learn as part of being a Balint group was principles of specific schools of psychotherapy, and that's not really the aim of the Balint group at all also, although that was probably in my head an error when I joined it. So I've dealt with the context of how I got into the group and what I learned and what I didn't learn. So what were the benefits and how did they really help in terms of dealing with the professional stress? One is, I keep thinking of Anna Karenina and the famous every unhappy family is unhappy in its own way. Same way, every unhappy client is unhappy in their own way. And that was something that kept on striking me as I was part of this group. And yet there are commonalities really in their unhappiness. And similarly, we as therapists respond in different ways, and yet there are commonalities. And this reassurance, this realization, was very reassuring to me. So for me, this was on a personal level a very key benefit. A second key benefit was what I realized from this group, because this group was especially there during the pandemic. I had to take a break in between due to health reasons. It was that it was okay to feel burnt out. And although when you're working in an institution, burnout is a crucial aspect. You are expected to work on it on a professional level with your students. You're expected to handle it on a systemic level in the institution. But it's also okay to acknowledge that burnout is there, and it's okay. And we should not feel bad that as specialists we have not been able to prevent burnout. It's okay to feel overwhelmed. And again, this was not a very stated aspect of the Balint group, but this was something that I learned being as part of the Balint group, and was really helped me deal in terms of dealing with the professional stress. And so how have these benefits really extended to the professional stress? The way I interact with my patients, a lot of the times my observation of my responses and my interactions with my patients has helped a lot. So, okay, this particular patient is coming. I am going to be a little more anxious, and it's okay that I'm anxious. I don't need to keep asking myself or forcing myself not to be anxious. Okay, these are the flashpoints. Maybe these are the precautions I need to take. And over a period of time, this is extended to my interactions with my students. And this has also dealt with the system, because as you keep getting promoted in institutions like St. John's, you do take on more of an administrative role. So you're not just dealing with patients and with students, you're also dealing with protocols, dealing with policies, you're dealing with people who are implementing them and their anxieties. And a lot of times there will be a stated objective, but there is something else that seems to be driving it. And the Balint group, maybe because of the technique involved in the group, has really helped me in terms of observing and subsequently dealing with my anxieties, and has definitely played a role in terms of how I have approached them. There is research to support this. There are papers published in Journal of Australasian Psychiatry also. To summarize, really, this has been a short presentation. In dealing with professional stress, where my experience in being with the Balint group has exposed me to different therapy experiences in a variety of different settings. And as Sivakami pointed out, that uncertainty is common as part of therapy has been very reassuring. And once that's been very reassuring, I have been able to monitor my own anxiety in dealing with these experiences. And that observation has helped me in terms of dealing with the stress. And a crucial thing, it's been mentioned several times in the previous presentations, when you're part of a Balint group, there's the sense that you're not alone. And that definitely helps in terms of dealing with the professional stress, considering that therapy in the end is between the patient and the therapist, and there always has to be those boundaries around it. With that, Dr. Ajit, I think that'll end my talk. I hope that's okay.
You're muted, Ajit.
Of course it is. If it's okay by you, then we start your session here. and your presentation here, and we've enjoyed listening to you. You did deal with the brief given to you very effectively. Any questions? We'd be glad to take them up in the discussion now for the next 10 minutes or so, after which we'll have a 5-minute break. After the 5-minute break, we are going to get on to something active. That is, there will be a Balint group actually in session, moderated by Mathew and Arun. And we have participants listed over here. I'll come to that soon. But there's one question already in the chat box, again from Nimisha, who's been quite active in today's session. She asks, I think this should be properly addressed to Sivakami. Is it providing a space to discuss interpersonal issues as residents from all years, junior to senior? Any of the experts could take it up, but I'd like Sivakami to go at it first because she's been dealing with medical students.
Right. I thought I'll clarify the question first.
Nimisha, are you there? If you could unmute yourself.
Yes, sir, I'm here.
Yeah.
Hello, good morning, everyone. I'm really enjoying the process so far. I'm interested because you told in your presentation with your experience that you are catering residents from first year to third year, right? So what being in a PG institute, right, they have a lot of trouble while, the interpersonal relationships and all. So do this kind of group provide a space for discussing such issues?
Yeah, thank you for your question, Nimisha. That's a great question, actually. And so in my experience so far, that hasn't really been a focus. I think the focus has been more about what goes on with patients or family members. And although, yes, and I think there has been we've tried to create space to acknowledge the general challenges that PGs have. And I completely agree with you in terms of how a lot of them, other than the workload, can be very interpersonal. We've had one particular session comes to mind, just one in the last 2 years, where somebody did bring in a sort of challenge that they were having in a team. And it was very challenging for me, I must say, in terms of trying to create adequate boundaries, keep attend to whatever was being brought, while also keep that general sense of trust and safety. But I must say that hasn't been the main focus. And I wonder what others think about whether that Balint groups extend, because there are other kinds of groups, right, for like staff support or reflective practice in teams or trainee support groups. So I wonder what others in the group think about that.
People who are involved in dealing with postgraduate training, even recently, Mathew, I wonder if you could take this up.
Yeah, I can, but I think Priya also would have some experience.
Yeah, definitely. Priya, Mathew, Arun, all of you have been involved with postgraduates.
Sorry, just to answer Nimisha in a very sort of lateral fashion. So Balint groups and reflective practice groups also are really not personal growth sessions. I mean, they don't deal with your own problems or issues. But as all the others said, Sabina, Sivakami, Priya, indirectly, it will really help. So if the students are going to discuss a problem that they faced with a patient, or some problem in a group, as Sivakami said, in a treatment group, and if that gets discussed in a reflective practice group or even in a Balint group where they're discussing patients per se, in some ways that will reduce your level of mastery or stress. I mean, it will improve your level of mastery and reduce your stress. So indirectly, it might help you. But those groups, staff support groups or personal sort of growth groups where people have problems and that can be addressed. That also is very, very much important. And I think Priya has got a lot of experience doing that at St. John's. And of course, I did that many years ago in the maths, but that's definitely necessary, especially in a medical school.
Right.
Yeah, so Priya here, I agree with Dr. Mathew. I don't think we must mix up Balint groups and staff support groups at all. The aims are totally different. Yes, I think indirectly in Balint groups, you may get a sense that there are some logistic issues coming in terms of if a particular series of cases keep getting presented again and again with a typical set of challenges that might shine light, and maybe at the end of the group someone can go back and just check with the PGs if there is a pattern that they're seeing again and again. But specifically to answer the question, I don't think the Balint group per se, the way it's being discussed here, would be the ideal format for dealing with PG stresses. There have to be separate groups and there have to be separate systems.
Right. So I think the emphasis is that all group interactions are not Balint group interactions. You could have a group interaction to resolve these issues too. But I think interpersonal matters, especially between students, would not be addressed in a Balint group at all. That's how I understand it. Please correct me if I'm wrong. Arun, any inputs from your side?
And to the question that Nimisha is asking, any chance to observe a group? You are going to observe a group.
You just asked that just before you asked that question, Nimisha, as I was announcing that there will be a break, and after that we will have a group. So, Arun, would you like to answer that question about senior and junior residents?
So yes, and I think that's a very interesting question. So for me, our Balint groups, therapy groups, they're not therapy groups. But are Balint groups therapeutic? I'd say yes, indirectly. So, and I think that's what Priya brought in, and I think that's what Sivakami was saying as well. At the end of all these sessions, you feel as though you've had a bit of a therapeutic input. So in that sense, I think it does relieve stress. The second thing I think it does is it sort of helps people look at, how can you be with another person? And perhaps I'm being a little vague when I say this. We learn throughout life how to be with another person. And you can be very objective. You can look at the other person as an object and then try and understand them, or you can be with the other person on a sort of a dynamic where you understand each other. And I think that's what Balint brings in a very indirect sense. So that way, I think it helps the residents be a part of a group, feel a part of a group, feel supported, and also learn to be with another.
Thank you. So I'll conclude this session by recalling what Priya had to say, that one gets the reassurance that one is not alone. Reminds me of Steven Spielberg's movie Close Encounters of the Third Kind, where the basic message is we are not alone. That's said in a lighter vein, but also heavy with meaning. And we'll break now. Go have your cup of coffee. Please be back in exactly 7 minutes from now. Sorry, 6 minutes from now. At 12:10, we'll start our next session. Arun, just 10 minutes behind schedule. Sorry for that. Now we have a group. Before we take the break, Dr. Lakshmi Shiva, Dr. Swetha Seth, Dr. Manjula, Dr. Bino Thomas, Dr. Sabina Rao, Dr. Arun Kandasamy, Dr. Priya Sreedharan, Dr. Rathna, and Dr. Sivakami will be in an active Balint group. You'll see how it really functions. And this group will be moderated by our usual moderators, Dr. Arun, Kishore, and Dr. Mathew Varghese. So you can switch off your video for the time being and get back here before 12:10. See you soon.